Hello, my name is Michael Sneed, Executive Vice President of Global Corporate Affairs and Chief Communication Officer at Johnson & Johnson. On behalf of our more than 135,000 employees worldwide, it's an honor to strengthen our relationship with the Congressional Black Caucus Foundation. We're proud to serve as a sponsor for this 2021 Annual Legislative Conference, Health Brain Trust Session, on the impacts of COVID-19 on Black mental health. We want to thank Congresswoman Robin Kelly for hosting today's discussion and for her ongoing leadership in addressing the critical healthcare issues impacting communities of color. In so many ways, the events of the last 2 years have shined a new light on the countless ways systemic racism permeates American society and the dire consequences that it breeds. COVID-19 has been an especially revealing experience, as it has disproportionately devastated communities of color across this country. This has been true not only as it relates to physical health, but mental health too. Studies have revealed that communities of color and groups such as essential workers, frontline health workers, and sudden caregivers have suffered the worst mental health outcomes as a result of COVID-19. Last year, after months of soul-searching and deliberation at Johnson & Johnson, we announced a new initiative titled Our Race to Health Equity. The goal of this program, which is backed by a $100 million commitment over 5 years, is to eradicate racism as a public health threat by cultivating our own culture of inclusion, investing in healthier communities, and forging enduring alliances. When we conceived this program, we had today's topic in mind. Racial health inequities, both physical and mental, exist for a variety of reasons, including cultural, historical, medical, logistical, and socioeconomic factors. We believe there cannot be justice in America until there is justice in healthcare. And to achieve justice in healthcare, we'll need broad partnership between business, government, academia, and community leaders. A forum such as this one that bring together committed parties from across society are vital. I'm looking forward to today's discussion, which I know will reveal new insights and help light the path forward as it relates to equity in mental health care. As you listen to this conversation, I hope you'll think about ways that you might partner with Johnson & Johnson in this critically important journey. Thank you again to the Congressional Black Caucus Foundation for the opportunity to sponsor this session. We are a proud supporter of your work and a steadfast partner in your commitment to advancing equality in healthcare. Enjoy today's session.
Hello, everybody. This is Omar Dorsey, and I'm extremely honored to introduce this panel as a part of the Congressional Black Caucus's Fall Health Brain Trust. Now, many of you may know me as Hollywood from the show Queen Sugar. The show was created by the incredible Ava DuVernay and executive produced by the legend herself, Oprah Winfrey. Now, this is a show that is based on a Black family living right outside of New Orleans. And for the past 5 seasons, it's been deeply rooted in reality. But for this last season, the show went a little bit deeper, a little bit further. We shut down production of season 6 of Queen Sugar in March of 2020, as all productions industry-wide did. We had just began filming, I remember. And I talked to Ava about what we were going to do, and she had an idea. She said, you know what, Omar, I think we're going to just flip the script. We're going to scrap what we have written, and we're going to address everything that's going on in the country. So everything from the pandemic and the way that it was affecting our community, you know, the murder of George Floyd and countless other men and women across the country who look like me, the divisive election, the rise of the Black Lives Matter movement and the protests that were basically taking place in all cities. 2020 was a lot. We want to use Queen Sugar as a place of support for the Black communities and to shed light on what was actually going on, to portray these storylines that would allow our community to process the year and to see themselves reflected. This is what we always want to do on Queen Sugar. Some of the issues that we have been experiencing, and to show people they weren't alone. Queen Sugar was a time capsule that we hope will endure. So as for me, my character, Hollywood, he was supposed to be opening up a new place called The Real Spot where cats could just come through, get a haircut, shoot the breeze, get a drink or two or whatever. And we still did that. But what we also did was make it a place where it was a safe haven for people to express themselves and to talk about their emotional traumas and what we were experiencing. To normalize letting it be known that it's okay to talk to your brother. It's okay to talk about the struggles that is going on in your life and to reach out for help. We want to show that strong men, they need help. And it's amazing when you have friends and you have brothers, you have this sense of fraternity that you're not alone. Like even myself, man, Omar, I walk around sometimes feeling like Atlas and having the whole world on my shoulders. But with this season, what it showed me in the writing, which Queen Sugar does a lot for me personally, it showed me a different route in a different way that we can take some of the things that are going on with us mentally, this mental health, that it could be something that just does not have to be your burden. That, like the old song says, he's not heavy, he's your brother. You lend a hand out to somebody who needs help, and sometimes you reach up when you need that help. And this past year showed me that way more than any other. So we wanted to use our voices and our opportunities to reach out to as many people as we possibly could, to support and encourage communities no matter what they were going through, because we understand that mental health and wellness is a serious topic that we need to take a look at. Given the impact that COVID-19 has had on mental health, aggravating and intensifying existing traumas and underlying health conditions, we need to come together with people like Representative Robin Kelly to support actual policy solutions to address some of these challenges and how we are treated as a Black community. I want to thank the CBC Health Brain Trust panel for hosting this event and hope that you are enjoying the conversation. Thank you.
Hello, everyone, and thank you for joining me for the 2021 Congressional Black Caucus Fall Health Brain Trust. I want to especially thank our hosting partners, the National Minority Equality Forum. The work of NMQF is so important in advancing health equity for communities of color. I also want to thank our sponsors and our wonderful panelists for sharing their time and expertise with us. Before we get into panelist introductions, let's talk about why we're here today. Today, we are coming together to discuss a critically important issue: Black trauma and mental health during the COVID-19 pandemic and beyond. Throughout our conversation, we will be highlighting some of the stressors and trauma that Black Americans have navigated during the past 18 months and discussing solutions for improving the mental health of communities of color, including increasing affordability of care, removing barriers to care, and destigmatizing conversations around mental health. While we are making progress in normalizing discussions of mental health, we still have a long way to go in reducing the stigma around seeking mental health care, especially in communities of color. That is just part of why today's discussion is so important. According to SAMHSA, only 33% of Black Americans with mental health conditions received treatment in 2019, compared to nearly 49% in the general population. Issues of inequity in healthcare access and lack of culturally competent care have existed for communities of color long before the onset of COVID-19. But this pandemic has shown an extra bright light on some of those health inequities, and especially on mental health care inequities. Before we begin our discussion today, I want to very clearly point out a few of the contributing stressors that have led to disparate mental health outcomes in Black communities during COVID-19, and why it is so important that we develop a targeted, intentional approach to improving healthcare access and standards of care for Black Americans. Throughout the past 18 months, COVID-19 has torn its way through the United States and the world. In the United States, communities of color, and particularly Black communities, have borne the brunt of this pandemic. Black communities experience higher rates of infection and death due to lack of access to care, and we continue to be concerned for these communities with the surge of the Delta variant. The physical impacts of COVID-19 were not the only health impacts of this virus. Black communities have been disproportionately impacted by the mental health impacts of the pandemic as well. A US Census Bureau survey found that COVID-19 associated mental health issues more adversely affected essential workers, young adults, Black and Latinx individuals, and unpaid caregivers to adults. We know that Black Americans account for many of our essential frontline workers, childcare providers, and caregivers to adults. While many Americans were teleworking to protect themselves from the virus, these essential workers were physically exposed to the virus while also navigating the stress and fear caused by that reality. Additionally, COVID-19 forced families to adapt to online learning, which required a parent or other caregivers to stay home with children, required a reliable and affordable broadband connection, and meant that many parents were attempting to take on the role of teacher or tutor while also teleworking. The reality during the COVID-19 crisis is that many women, and especially Black women, were forced to leave the workforce altogether to care for children at home, creating additional financial hardship and stress. Other family dynamics have also been put to the test during the pandemic. Of course, folks all across the country were struggling to safely connect with family members, ensure that elderly and immunosuppressed loved ones were protected from the virus, appropriately cared for, and not left alone. Unfortunately, many were also mourning the loss of loved ones. I personally lost 2 people in my family to COVID-19, and I know how difficult that process was for me and my family. To make matters worse, throughout the COVID-19 pandemic, we watched as Black Americans were brutalized and murdered by police. These injustices inspired Black people across the country to carry the burden of protesting police brutality, standing up for our rights, and leading a national discussion on the unjust ways Black people are still treated in America. Any one of those issues alone is enough to create a mental health care crisis. Unfortunately, on top of all of that, we are navigating how to bring mental health care to communities that have been underfunded and underserved for generations, intentionally cut out of reliable public transportation, and for too long left out of conversations like the one we are about to have today. As chair of the Congressional Black Caucus Health Brain Trust, it is both my duty and my honor to champion issues of health equity for Black Americans. Together, we can and will overcome these barriers to care and improve the care available to Black communities across the United States. The open and honest conversation we have here today will inform future policy priorities and solutions for the Congressional Black Caucus, the conscience of the Congress, and serve as just one step in our ever-evolving journey to establish real health equity for Black Americans. But no pressure. With that charge, I want to kick off our discussion by first introducing our moderator, Dr. Anita Burgos. I know Anita as my Senior Health Policy Advisor. In this role, she leads my health policy initiatives and advises me on health issues before Congress. Before joining my team, Anita served as a Senior Policy Analyst for the Bipartisan Policy Center leading the behavioral health portfolio and pulling from her experience as a caregiver to a family member with a mental health condition. As part of that work, she co-authored various reports, including a report on how to better integrate mental health and substance use services into primary care. Before joining BPC, she worked on healthcare policy for Senator Tina Smith as an American Associate for the Advancement of Science Fellow. Prior to her work in health policy, Anita was a research scientist at Columbia University. Anita attained her PhD in neuroscience from Columbia University. While in graduate school, she led bilingual initiatives to bridge the gap between scientists and the community and between scientists and policymakers. So I am very fortunate to have Anita on my team, and I'm looking forward to her sharing more of her neuroscience and mental health expertise with you all as our moderator today. Anita, I will now turn things over to you to introduce our panelists and get us started.
Thank you all for tuning in to watch the CBC Health Brain Trust on Black trauma and mental health during COVID-19 and beyond. As Congresswoman Kelly addressed in her opening remarks, mental health and trauma impact every single community in our country. But today, we're going to focus on how it impacts Black communities. As we'll continue to highlight today, Black communities are not a monolithic group, and the stigma and challenges to accessing mental health care can vary by gender and by ethnicity across Black communities. Mental health and the brain more generally are not only topics that have long fascinated me throughout my professional career, they're also deeply personal to me. I'd like to start off by sharing a little bit of my mom's story with you before we get started. My mother is a Latin immigrant from the Dominican Republic, and she has lived with serious mental illness for over 30 years. I am her primary caregiver, although these days my role is more of a supporting role as I encourage her through her healthcare journey. After a series of hospitalizations throughout her entire life, she is finally in a more stable place. She has a psychiatrist, a licensed clinical social worker, a primary care provider, and up until recently, a care coordinator, all of whom are women, Spanish speaking, working together to ensure the best quality care for my mother. And as a result of this team, she feels empowered by her health team to actively participate in her mental and physical health care, and she trusts her providers. My mom's team has been vital throughout this pandemic. My mom lives in Queens, New York, ground zero of COVID-19. In Queens, 10,000 people have died due to COVID-19 related deaths. That accounts for 1 in 3 COVID-related deaths in New York City. As a caregiver, I noticed an increase in my own anxiety, and my mother, who lives alone, felt afraid and isolated. Telehealth, particularly audio-only services, were the only way that my mom was able to connect with her providers throughout this pandemic. She didn't have a smartphone until recently, and because of fears associated with her condition, didn't want to get a smartphone. During the pandemic, my mom has even started attending weekly support group sessions in Spanish, and and through the telephone, and they've allowed her to remain connected to her provider, but also to remain connected to her peers. These tools have not spared my mother from feeling isolated, anxious, and sad, but they have offered some meaningful connections and support when she needed it most. I wanted to share this story today to illustrate some of the themes that we're going to be discussing during this panel. What did mental health and trauma look like in Black communities before the pandemic? How did COVID-19 make it worse? And what are some promising solutions that can be implemented in Black communities? And with that, I want to introduce you all to our all-star panel. I'm so honored to be sharing the virtual stage with everyone here today. So let's start off with Dr. Brandy Jackson. Dr. Jackson is a psychiatrist and co-founder of the Institute of Anti-Racism in Medicine, a nonprofit organization dedicated to the abolition of racism in the field of medicine. Dr. Jackson earned her bachelor's degree in human development from Cornell University and her medical doctorate from Northwestern University Feinberg School of Medicine. Dr. Jackson currently serves as the Chief Behavioral Health Officer at Howard Brown Health Center. She is also an adjunct professor of psychiatry at Rush Medical Center in Chicago. Next, I want to introduce Dr. Miriam Delphin-Rittman. Dr. Delphin-Rittman is currently the Assistant Secretary for Mental Health and Substance Use in the United States Department of Health and Human Services and the administrator of SAMHSA. She has worked at SAMHSA in the past during the Obama administration as senior advisor to the SAMHSA administrator. She previously served as commission of the Connecticut Department of Mental Health and Addiction Services and served in this role for 6 years. In her role as commissioner, Dr. Delphin Rittman was committed to promoting recovery-oriented, integrated, and culturally responsive services and systems that foster dignity, respect, and meaningful community inclusion. Dr. Delphin Rittman was an adjunct associate professor at Yale University, where she served on the faculty for the past 20 years. She received her BA in social science from Hofstra University, her MS and PhD in clinical psychology from Purdue University, and completed a postdoctoral fellowship in clinical community psychology at Yale University. Last but not least, I want to introduce Dr. Joshua Anthony. Dr. Anthony has focused on reducing health disparities for over a decade. Today, he continues to build upon that foundation as an American Psychiatric Association SAMHSA Minority Fellow and an HBCU Cares Behavioral Health Ambassador. Committed to reducing mental health stigma, Dr. Anthony is currently completing his psychiatry residency at Meharry Medical College, where he cares for patients with mental illness from all backgrounds. Dr. Anthony leverages social media to scale up his voice as the therapy doc to increase mental health awareness in underserved communities through content that is both funny and culturally relevant. Dr. Anthony received his BS in biochemistry from Oakwood University and his medical doctorate from Meharry Medical College and his master's of business administration from Northeastern University. So with that, I want to first turn it over to Dr. Jackson for some opening remarks. Or for her remarks.
First of all, I want to thank you, everyone, so much for having me. Thank you to Congresswoman Kelly and to the Congressional Black Caucus for just having me for this really, really important discussion. My name is Dr. Brady Jackson, and these days, the doctor part is what stands out. But for me, inside, I am first and foremost a Black woman. And what I and we have lived through and are living through as a community is something that I could not have imagined. Right now, I work at Howard Brown Health, which is a federally qualified health center in Chicago, Illinois. We see folks regardless of ability to pay. And there I lead up the behavioral health and social services division as Chief Behavioral Health Officer. My other identity, though, is co-founder of the Institute for Anti-Racism in Medicine. And all of these identities come to bear on what I feel like is my purpose, which is to give a platform to really the pain of the Black community in a way that it hasn't been offered before. I am pretty new to this space of being a Chief Behavioral Health Officer. At the beginning of the pandemic, I was a psychiatrist practicing on the south side of Chicago, seeing patients every day. If you had asked me before 2020 about the state of community mental health, particularly mental health for Black Americans, I would have told you that we were a system in crisis, that my patients were not included at the table, their interests were not included at the table when these systems were really designed and implemented. It's clear to me, clear to them. And I remember over a year ago in Chicago and seeing some of the initial numbers, the mortality numbers, and how disproportionately affected Black Chicagoans were. And I remember sitting with patients who said to me, Dr. Jackson, I don't feel like medicine remembers me. I don't feel like hospitals care about me. And I had this moment, and remember, I'm a psychiatrist, so my job is to dole out hope. I had a moment where I didn't have hope to dole out. I too had lost hope in my own profession. And it was a dark, dark day that ultimately led to me joining healthcare administration. I think we have a unique opportunity here really to tell the truth about Black trauma, to understand that when we talk about trauma, we can talk about soldiers in war, we can talk about folks who've experienced all kinds of assaults on their being. But the core insult, one of the core insults in our country is to Black Americans. It began with slavery. It continued, as so many have observed, with our criminal justice system. And today, like Martin Luther King spoke about decades ago, it is continuing through our healthcare system. It is my singular purpose to speak openly about the trauma that Black Americans face every day and how COVID-19 has truly not created, but exposed really the vulnerability of our healthcare system when it comes to mental health care for Black Americans. I'm young, but I never thought in my lifetime I'd see this topic get the platform that it has gotten. I always bring a spirit of hope that the time is now for us to tell the truth. And I'm so pleased and happy to be a part of that. So thank you for having me.
Thank you, Dr. Jackson. I appreciate you starting off the panel that way and expressing what you've seen on the ground and what you felt yourself during the pandemic. So thank you for doing that. And now I'm going to turn it over to Dr. Delphin Rittman for her remarks.
Thank you so much, and good afternoon, Congressional Black Caucus Foundation members. Again, I'm Dr. Miriam Delphin Rittman, and I was recently confirmed as Assistant Secretary for Mental Health and Substance Use at SAMHSA. I would like to thank you for including me in today's discussion. I appreciate Congresswoman Robin Kelly's invitation and applaud her efforts to improve the health and wellness of vulnerable communities across the country. I'd also like to thank you for focusing on issues impacting Black trauma and mental health during COVID-19 and beyond. I appreciate that we're having this conversation to uplift and address these very important issues. COVID-19 has revealed deep-seated inequities in health for communities of color. We know that Black Americans are 3 times more likely to contract COVID than white Americans and twice as likely to die from the virus. We also know that Black Americans have received fewer vaccinations compared to the general population. And while the rates of behavioral health disorders may not differ from the general population, Black Americans have lower access to treatment services, as shown by SAMHSA's annual household survey on mental health and addictions. 46% of Black American adults reported they had increased stress and mental illness over the past year, yet 21% of those surveyed received services for these issues. Black communities are also coping with historical trauma and intergenerational racism. SAMHSA defines individual trauma as an event, series of events, or set of circumstances that are experienced as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on an individual's well-being. Others have gone further to define racial trauma as the mental and emotional injury caused by encounters with racial bias, ethnic discrimination, racism, and hate crimes. In fact, the CDC declared racism a public health threat this past April. And so you might ask, what is SAMHSA doing to address these issues? SAMHSA's mission is to reduce the impact of substance use and mental illness on America's communities. We do this by directing federal resources and programmatic and informational solutions to ensure vulnerable communities have access to mental health and substance use treatment, prevention, recovery services, and supports. Having culturally concordant behavioral health workforce is a crucial element, and some of you might know I'm a product of SAMHSA's Minority Fellowship Program. Since 1974, the program has grown the nation's diverse racial and ethnic behavioral health workforce. MFP fellows go on to serve in key leadership positions in behavioral health services, research, policy, program development, training, and administration. And I can say certainly without this opportunity, I might not be here before you today. SAMHSA has also established the African American Behavioral Health Center of Excellence housed at Morehouse School of Medicine. Their work is grounded in 4 areas, including to increase our system's capacity to provide high quality care, to disseminate culturally appropriate evidence-based practices, to increase workforce development, and to infuse SAMHSA-funded entities nationwide with culturally appropriate information to improve services. As an additional example, in 2016, SAMHSA created the Resilience in Communities After Stress and Trauma RECAST grant, with the goal of providing communities facing civil unrest with resources to assist families who have experienced increased stress and trauma to build resilience, increase youth engagement, and support violence prevention programs, and trauma-focused interventions. We recognize that COVID's aftermath will continue to impact communities across the country. I do see rays of hope, though. The administration has prioritized racial equity as a fundamental driver of the government's work. Unprecedented resources are being directed to states and communities across the country to support and sustain robust continuum of prevention, intervention, treatment, and recovery services. And increasingly, courageous individuals like Simone Biles, Naomi Osaka are speaking their truth and having once stigmatized conversations about behavioral health. We know a population-based approach that focuses on social determinants of health is necessary to address the crisis. Thank you for today's convening and for inviting me to participate. It takes a village to address these intractable issues, and I look forward to working with you as we continue to expand effective and efficient access to behavioral health care for Black Americans across the country. Thank you.
Thank you, Dr. Delphin Rittman. I'm so excited about all the different perspectives that we have here on the panel today. And so with that, I want to pass it over to Dr. Anthony to provide his remarks.
Thank you for having me here. My name is Dr. Anthony. I am currently a psychiatry resident in Nashville, Tennessee, where I also graduated from Meharry Medical College. Currently, I am also a minority fellowship participant from SAMHSA. My project that is being funded is actually the development of a mental health app that addresses issues of aloneness, depression, and suicide within the Black community. My background is one like many other Black young males. I grew up in a single parent home. My father was in and out of the prison system, suffered from substance abuse. Unfortunately, this kind of colored my interaction and my perception of different organizations like law enforcement and things like that. I've seen my father arrested. I've seen unfortunate interactions. My uncle was shot in the back by police officers while he was handcuffed when I was very young. So growing up for me, this definitely developed, how I view certain organizations that may have been intended to protect us, or that we would think are intended to protect us. And so I think that I can really relate to the community at large when there are feelings of distrust towards the medical establishment, towards the law and justice establishment. And for me, when I see my patients, I believe that's where we really connect. I think it's very important for us to have providers that our patients can relate to, that they feel free and open to talk to. Unfortunately, right now, we are very underrepresented in the mental health field. There are less than 5% of psychiatrists that are Black and brown. And so I think one of the main ways that we can start working to address issues of accessibility and issues of mistrust is to start by helping to increase the number of Black and African Americans that are actually available to provide these services to the community. We know that Black men are far more likely to follow the advice of healthcare providers when they are Black or African American. And so one of my goals as a Black psychiatrist is to encourage the next generation to pursue fields within mental health, to provide representation via images, stories, videos, through social media to encourage whoever it may be to really take a serious look at providing mental health. I think that it really is the next frontier. As has been stated several times, there are a number of disparities that exist just in general across our community, especially within the healthcare field, and even more so within the areas of mental health and substance abuse. And so it's my hope that through platforms like this, we will continue to address those, to continue to decrease stigma, to continue to encourage transparency, and to just continue to share and talk about our shared experiences, because we all know what it's like, or we have a family member who's been in a tough situation. We all have issues, or we have to manage our mental health. And so I really hope to continue to spread the message that it's okay. It's okay to not be okay. It's okay to have a bad day. And it's okay to step back and reevaluate and really assess where you are. And so thank you again for having me here. And I'm looking forward to this conversation.
Thank you, Dr. Anthony, for those remarks. And so with that, we can start our kind of more conversational discussion. But before we jump into the questions, I wanted to ask, how is everyone doing today?
I was going to say, I am lucky to be in a place of peace today. Peace has become my highest ideal lately. So I'm very lucky. I feel good. Thank you.
Good. I'm glad that you all are here today and feeling good. I know this can be a heavy topic, and even for myself, as I speak about this stuff, sometimes it can weigh on me. So it's kind of nice to be with people who understand that. So the first question I wanted to address to Dr. Jackson. So Black communities here in the United States have been known to rely on family and extended communal networks for critical support tasks. How has the social distancing and the social isolation during COVID-19 placed increased stressors on the Black community, and what impact did this have on Black mental health?
I think it's such a beautiful aspect of Black culture. Not that we are a monolith, but many folks in the Black community do rely on each other to get through tough times. We all know that's a historical mandate for us to have made it this far. And so when it comes to being isolated from community, so too is the effect on us disproportionately bad. I know for me, I talk to my mom a lot. I talk to my parents. I talk to my twin sister, who's also a physician here in Chicago. And there are days and times when that is a lifeline. For other people in the Black community, there really is an instrumental requirement for community, meaning I can't get my kid to school. I can't be there at all places without the help of my friends and loved ones and family in the community, spiritual community. And right now, all of us have been called upon to really reach out for our coping skills, as we call it in my profession, those things that make tough times bearable. And when one of your greatest tools, which is community, is disrupted, the way that COVID has disrupted Black communities, it's really tough. And sometimes we're left with just ourselves, which is, I would say, something no human was really built for. And I think that anything that we can do to build community, whether it's virtual, whether it's on the phone, is something to take really seriously, because I think Black Americans are disproportionately harmed by the isolation.
That's right. And you started touching on this a little bit, how Black communities are not monolithic, and there's Afro-Latinx, there's other immigrant communities. I know, as a daughter of immigrants in the Dominican Republic, I've heard so many stories about the language barriers, the high expectations, the isolation that can accompany being a new immigrant in this country. So how do you think each of these, Dr. Jackson, impacts healthcare seeking behavior and access, and how does it affect the willingness to get help?
When you look at how healthcare is structured, how it was built, and you think about the mechanisms we have of outreach, I often reflect on the fact that there's not a lot of places to get health information for Black Americans that is in our language, meaning not overly sterile and critical. We're, again, knowing that we're not a monolith, we're a people who speak plain. Where I'm from, we speak plain. And there's just not enough plain speaking. So I think that's one thing. And when you start adding identities to Blackness, so when you say, I am a Black person who is also a member of the Latinx community, I am a Black person who is also a member of the trans community, or whatever those identities are, as you add complexity, each one of those identities brings with them unique ways of receiving information and seeking information about mental health and unique views on mental health. It's really, really complex, but I think what it boils down to is really medicine needing to step up their game. Medicine, meaning my profession, especially mental health, needing to be more flexible about how we deliver information and deliver care. It's really hard for some of us to ask for help. I'm literally a psychiatrist myself, and the first time I went to therapy, I was in med school. And I realized, or I thought in that moment, I have lost it. I thought I was crazy. I thought it was the end for me. And that fear came despite my immense privilege to have access and all those things. So it's a really hard thing in our community for many of us to just name mental health as an issue. And my profession needs to make it easier.
Yeah, I think that's right. And as I ask these questions, feel free, Dr. Delphin Rittman, Dr. Anthony, if you want to say something, you can feel free to jump in too.
Yeah, I'd like to jump in on this part of the conversation. I agree. I mean, I appreciate your point, Dr. Jackson, about just stigma and how stigma can sometimes be a barrier to reaching out, and so we know that there just is a lot of stigma related to mental health, and increasingly having conversations like this. Sharing stories of, that it's okay not to be okay. As you said earlier, Dr. Anthony, the accessing services and supports. I think the more that we have conversations like this, the more people I think will be likely to access services and supports. So I appreciate all the sharing that's happened on the panel up to this point, because I think it really does help to show people these are everyday conversations. We have conversations about diabetes. We have conversations about having a headache. It's okay to have conversations about mental health. Mental health is part of health. And so, these types of spaces are critical for, I think, elevating and uplifting that.
Yeah, I couldn't agree more with that. And Dr. Delphin Rittman, let's stay with you for a little bit longer. So I know that you have a lot of experience with culturally responsive care. I've seen this be so effective in action. This is the reason why my mother is still engaging with her care. She has providers who look like her and speak her language, and there's trust there. So based on your research and experience, what are the largest barriers to culturally responsive care? What are the opportunities within training programs for providers and within our current payment system to start prioritizing cultural competency?
Yeah, no, thank you for that question. It's so critical because we know, as you said, culturally competent care can make a difference. When a provider or an organization or a healthcare system is culturally responsive, people often feel heard, validated, more likely to access care, more likely to let other people know about the care that was useful. And so it's so critical. I would say one of the barriers is, thinking about cultural competence as like this endpoint that you can take a training, or if you're a executive director of an organization, you can schedule a couple trainings and hire some diverse staff, and that's it. You've reached that endpoint. And I think that's the thing that's often misunderstood about cultural competence, that, cultural competence is it's a dynamic process. It's an ongoing process of thinking about sort of competencies at multiple levels, the individual provider level. For example, as an individual provider, How aware am I of my automatic thinking? How aware am I of my own biases and the way that impacts my interaction with others? Or if I'm the head of an organization, what is the extent to which I have policies in place related to hiring, related to grievance policies and procedures? Do I look at my data in terms of health equity and have that data inform my decision making? So we know cultural competence is it's a dynamic structure. It exists at the individual level, at an organizational level, and at a system level. HHS, so the Department of Health and Human Services, the Office on Minority Health, has put out standards, which they call the Cultural and Linguistic Appropriate Competence Standards. And those standards essentially are 14 standards that can, if implemented, we know can help to reduce disparities, can help to promote quality care, and to promote equity. It addresses things like workforce, language and communication, community engagement, and continuous quality improvement. And so I think that the main thing I'd like to sort of communicate is this, that cultural competence, it's a multidimensional sort of process. It needs to be thought about ongoing. And to the extent that we really pay attention to it and hone into it, it can help to reduce disparities and build bridges across communities. So I think there is real value there to prioritizing cultural competence, both within individual provider care, but also within organizations and systems. And there are tools out there that can help providers and systems with that the Office on Minority Health has put in place.
And I couldn't agree more, Doctor, with what you're speaking of, the levels of cultural competency. I think that gets lost a lot. People get stuck on the individual, or they get stuck on the organizational and think they don't have to work on themselves as well. And I would add that layer of, and I think you were getting to this or getting at this, which is how some folks have an idea that there's a way you can passively become culturally competent, meaning if I sit on enough seminars or I go to enough places and listen, I will just get imbibed with this knowledge. But the truth, as I understand it, is there is an activeness, a way of seeking out people, places, situations that feel maybe even uncomfortable to you because they're different than your experience. And I think we have to push ourselves to not just be passive receivers of cultural competent learnings and trainings, but also ask ourselves what action we must take to immerse ourselves in other cultures.
Yeah. I just have to say, I love what you said about push ourselves to be uncomfortable. I think that's such an important construct or part of being culturally responsive. It means sort of getting out of our boxes or our comfort zones, be willing to lean into another person's life space and try to better understand what their experiences may be or have been. And I think to the extent that we do that within a clinical encounter, that is ask questions that help to build bridges and better understand a person's life space, people feel heard. They feel heard and valued, and that helps to bring them hope. You referred to hope earlier, and I think cultural competence can help to instill hope when a person feels it, when they feel like they've been heard and seen.
Yeah.
And if I can add, I would say from an organizational perspective, we have to make sure that our leadership positions are diversified and that these positions have individuals who are able to make these decisions and able to push these initiatives that, that are cared about. When I was interviewing for residency, it was funny, there were two places that I remember. One of my interviews, I didn't see any Black male residents. And when I was interviewing with the program director, I asked him directly, why don't you have any Black men in this program? I went through your pictures of the previous classes, and it doesn't look like you've had a Black man as a part of this program for at least 15 years. And his response was, well, because we don't have any Black men faculty. That wasn't a good enough answer to me, but also for me, it highlighted, the importance of having individuals in a position to advocate and to, speak on behalf of the issues that we care about and the things that are important to us. Another interview that I had, the program director, I think he lectured me about my beard. And to me, my beard was fine. It's like it is now. But to him, it was too long. And so, just from a cultural level, for me, as somebody who works with Black people a lot, the majority of the time, that's part of the way that I relate, And when they see me with the beard, they're comfortable with that. That makes them feel like they can relate to me. That makes them, more likely to open and share. So I definitely think, when we're talking about any group, reaching any group, if we don't have members of those groups that we want to reach out to, that we want to meet, then any initiative that we make is almost doomed to fail.
Yeah, I think that's absolutely right. And I'm honored that there are so many leaders here on this panel right now. So you are all, inspiring people who are younger to go into positions of leadership within the mental health field. So I think that is a wonderful thing to highlight as well. So Dr. Anthony, I wanted to stick with you. And you talked about this during your remarks, which I really appreciated, kind of the trauma that you've seen in your life and sort of how you can use that to relate to your patients. I kind of want to focus a little bit, if you wanted to speak a little bit more about that, that would be great, but also wanted to hear a little bit more about what platforms or spaces help bring Black men together to connect and heal.
Yeah, definitely. So I talked about it a little bit, but my background, I grew up in a single parent home, not a lot of money. My father was constantly in and out of the house, in and out of prison. And so that definitely shaped my perspective of a lot of different types of organizations and systems. I grew to be very distrustful of police officers, of, any kind of law enforcement. And so for myself personally, started to realize that, certain things were happening to me, like anxiety. I even saw a police officer, it just caused this, unnecessary feeling like something was about to happen or like I was in danger, even though I wasn't doing anything wrong. And I think that, a lot of Black people can relate to that. Research has shown that a lot of Black community is walking around with PTSD that, is going untreated, going unaddressed. And, every day we kind of just have to deal with it, try to make it to the next day. And so, there's things that we have been doing, spaces that we have had historically, for Black men. One of the main ones is the barbershop, and I think that space is actually starting to be highlighted more. There are organizations within medicine that are headed by people of color that specifically go into these spaces. So Shop Docs, led by a colleague of mine, two other colleagues of mine, Dr. Atalo Brown, Dr. Jamie Rutland, they're starting a barbershop series. And then even, I believe I think it's called the Barbershop, but with LeBron James, and they have a lot of other individuals, and they talk about things like this.
But to follow up on that discussion, I think that's right. Like those physical, I've heard about that too, barbershops. There's also I think it's called the Confess Project, that's trying to get kind of work with folks who work in barbershops to talk to their clients as they're cutting their hair and kind of do some interventions too, like while they're talking with their clients. So I think that's a really promising space. I think what has been difficult during COVID-19 is not being able to be physically in those spaces. And so wanted to ask Dr. Jackson, what do you, given the rise of telehealth during the pandemic, do you see this as a promising platform for increasing access to mental health in Black communities?
I'm actually loving telehealth for us. You know, when early before the pandemic, there was a lot of talk of the inferiority of tele platforms, whether, to me, I do not, this is how I look at it. I want more high quality access to mental health care for Black people. So to me, anything that lowers barriers, I mean, even especially physical barriers, is something that we should be interested in for our community. We've got a lot of barriers. And the other piece of that, though, is, and I would argue the most important part, is who's on the other line. Are they, as we say, culturally competent? Are they affirming to the person's identity? That's what I care more about. I will say, though, that during the pandemic, what I saw was that there were many patients and many Black people who didn't have access to the video component. So I always think if you can see somebody, look in their eyes, and again, maybe it's that cultural piece, that trust piece, it's always the best. It's so I think telephone only, you know, I have some concerns, but if it's telephone only versus nothing, which really is the choice that many Black Americans have to make, give me the telephone and spread it, if that makes sense, happily.
Dr. Delphin Rittman, was there anything that you wanted to add to that?
Yeah, just, you know, I agree fully, and certainly have heard this quite a bit from community providers really across the country, certainly in Connecticut, but in meetings with other states, you know, hearing state leaders talk about that people have really appreciated the opportunity to connect with healthcare providers via telehealth. And there's, you know, quite a bit of interest in that, you know, continuing as an option. For people that have challenges with transportation, you know, it addresses barriers with transportation or childcare or having to go to work, or sometimes people just have a preference of speaking with their provider or connecting just from home. But there is a quality piece, and there are studies that are bubbling up. They're beginning to look at that. You know, is the quality the same when it's video versus telephone only? Video also, you know, it gives other information, other visual information that can help with building a therapeutic alliance and connection. You know, some of the nonverbals, which we know are important for relationship building and connection. But the point is critical, though. If it comes down to a video or no, or just phone or not connecting at all, then, you know, certainly the video or connecting via phone is better than not connecting at all. So telehealth does show real promise. It shows real promise as a way to increase access to services. And we know some people have those particular preferences related to sort of connecting via telehealth as opposed to in person. AARP actually did a study looking at this. And African Americans and Latino individuals showed a greater preference for telehealth versus other groups. But then when we look at the data also shows that African Americans and Latinos were more likely to connect via non-video telehealth, so just by phone. And so, you know, it raises, you know, is the full quality there? And so those are things that we have to look at and consider.
Yeah, and just to chime in here from my my personal experience, my mother had a pre-existing relationship with those providers. So I think that's something else that policymakers are thinking through, because if you have that relationship, then it is a little bit easier to shift to something like audio only. So that's something else that policymakers have been considering. And Dr. Anthony, it looks like you're back. So if you want to say anything about this about telehealth, or sort of the spaces that Black men congregate and how they heal, feel free to jump in now.
Yes, sorry about that. Yeah, I definitely agree. I guess for me, my experience, I have worked some with telehealth, but really where I'm reaching a lot of Black men and other Black individuals is through social media. I think that's another relatively untapped avenue, but I'm starting to see more and more organizations and therapists starting to utilize it just to get messages out, just to provide resources, to provide information. And I'm seeing that taken advantage of across the community. Several individuals have contacted me to let me know, like, hey, I really appreciate it. You posted it about this, I was dealing with, the same thing, and I didn't know who to talk to or how to bring it up. But it's just good to know that someone else is experiencing the same thing. Because what I was saying before I got disconnected was that, a lot of times Black men aren't really encouraged to talk about their feelings. And a lot of times we have to deal with the stigma that goes along with, expressing mental health struggles, but also with things like toxic masculinity and hypermasculinity that says that, it's not okay to express vulnerability or weakness. Even though, like it was said earlier, if you have a headache, it's okay to say that you have a headache. If you hurt your knee, it's okay to say that. But for some reason, we put our mental health in a completely different category that is not supposed to be impacted by anything that happens to us on, a day-to-day basis. And so I would definitely say that that stigma is a barrier to access for Black men. And then just from what I've seen, Black men are most comfortable with being able to talk to other Black men. And so, I would love to see more Black male therapists, more Black male psychologists and psychiatrists, just to open up that space even more, and to help provide that space for Black men, to be open and honest and vulnerable and transparent about the things that they experience.
Yeah,
It,
that's right. Go jump in.
If I may too, I just moved my spirit. I want to acknowledge that we in this room and many Black mental health professionals, we're asking Black people to do something that has historically been completely unsafe. So I just want to name that when we talk about how hard it is for Black people to speak their pain and show their pain and be vulnerable, we have to also think about the historical context there. And I know all of us do, but I just want to name for folks who may be listening, it was threatening in the past if you showed on your face your own vulnerability or you showed on your face your own pain, it could put a target on your back. Still does in many places. And so I also think the challenge in creating space for Black people to open up is that we also have to be creating safe spaces to do so, whether it's on the internet and social media, which is why Dr. Ipede, I think your work is so awesome that I totally need to get on social media, and I have to, I'm gonna just do it. But I think those spaces that are especially created by Black folks gives us that opportunity actually to safely express emotion.
Yeah, thank you for making that connection and giving us a little bit more of a historical context. Dr. Delphin Rittman, did you want to add something?
No, I think that's such an important point, just the safety piece and how important it is for us as healthcare providers or healthcare leaders or policymakers to think about sort of creative and innovative ways to create safe feeling entry points and entryways into the healthcare system. Connecting with faith communities. I've so appreciated learning about and now funding innovative community programs that connect with faith communities as partners in helping people to ultimately connect with behavioral health services and supports. There is long-standing research that shows people are sometimes more comfortable talking with their preacher or other informal supports that they may encounter in a church setting than a formal provider. So that's potentially a really valuable relationship. Healthcare providers or behavioral health professionals connecting with faith leaders. And collaboratively building programs that sometimes even meet in churches or in faith spaces or community spaces. And so there are a number of innovative programs across the country that sort of are using that model, building creative collaborations with faith communities to help increase access, particularly for African Americans, Latinos, others as well, but a few programs that I'm aware of with African Americans and Latinos to help increase access. So I appreciate your comment about the safety piece, because people sometimes are reserved, and it's not necessarily culturally congruent to, people will say to share my business. I was sometimes here, I did a study years ago and about help seeking, and people said, well, I was raised that, what happens at home stays at home, and we don't put our business out. And so now it's, how do we begin to shift some of those narratives so that people feel that it's okay to reach out and it's safe to reach out. And so yeah, thank you.
Yeah, I want to stick with that point for a little bit longer. One of the things that is getting a lot, has existed for a very long time, but is getting a lot of attention now, is peer support specialists. And I know we're sort of talking about this a little bit, having someone who you can relate to. And I know we have doctors on the call, but there are also other community-based workers who can really provide that cultural competency piece, but may not necessarily have a medical degree. So if any of the panelists wanted to kind of comment on the role of peer support specialists and how they can work alongside clinical staff or complement clinical staff in providing that cultural competency and that support to individuals who are experiencing mental health conditions.
Yeah, I mean, I'd be happy to speak to that. I mean, I definitely have seen that, across the behavioral health work field, that peer support specialists are a real valuable segment of the behavioral health workforce. They help to bring people hope. They show people that, look, I have lived experience and I've had these experiences, and they're in many times, living examples that a person can live a full, whole, meaningful life alongside any symptoms that they may be having associated with their mental health or substance use challenges. There are initiatives across the country where people in recovery from substance use, and in some instances mental health challenges as well, will meet people at emergency departments. So if a person is brought to an emergency department with a substance-related medical emergency, a recovery coach is there and meets with them and shares their story and helps connect them with services and supports. And often, people do feel that connection when the person is from the same cultural background and shares their recovery journey and helps to give them hope. So I've seen real value there across both the mental health services and supports, as well as substance use. People in recovery, I'm experiencing both, working with people who are needing to engage in access and connect with services.
And I love that point. And I also, to me, think that we, especially doctors, but anyone in healthcare who does not identify as a peer specialist, have to think about the ways in which we should be peers to our patients. In other words, we should be sharing our own humanity, breaking down that hierarchy. Full disclosure, I haven't worn my white coat since I graduated residency for the most part. No disrespect meant, it's just, I noticed in the communities where I work, it is not something that is bringing comfort, it's bringing a separateness, or this idea that I'm some expert over here, come to tell you how to fix your life. And truly, I view my role as to be a student of my patient, to learn from their own experience. And I think peer specialists are uniquely qualified to do that. They are folks who have shared literally the experiences, but I also think we all have shared some common things like pain, probably not racism for all of us, but for me as a Black, I have. So when I'm in a room with a patient, I bring that. And I think those are some of the most strong moments of healing, when I've noticed the ways in which me and the person in front of me are actually peers.
And I think that's so important, because in this field, unfortunately, a lot of times we're discouraged from self-disclosing. And I think that really takes away from, the patient-doctor relationship, because, that's exactly why the patient is coming to you, because they need somebody that can relate to them and that can really just see them. A lot of times people just want to feel seen, they want to be seen. And so when we don't self-disclose, or we, put up this wall kind of, I think we really take away from, from a huge part of our toolbox, in being able to meet individuals where they are, and being able to help them in their healing process.
Yeah, I think that's beautiful. And I love that you all are talking to your peers, your provider peers, and saying, hey, it's okay to show that humanity. I think that's really beautiful. We started talking during the peer conversation, we started talking a little bit about substance use disorders, and I kind of wanted to turn to that. So preliminary data from the center from CDC is showing a 29% increase in overdose deaths in 2020. These otherwise preventable mortalities are driven primarily by the opioid epidemic, but increasingly include polysubstance use and other deadly substances like methamphetamine. Dr. Delphin Rittman, could you speak to the co-occurrence of substance use and mental health conditions and what this looked like before and during the pandemic?
Yeah, absolutely. Thank you for that question, because it is something that before the pandemic, we saw quite a bit of co-occurrence. And even now we see quite a bit of co-occurrence of both mental health and substance use disorders. We know for many individuals who may be struggling with mental health challenges, sometimes substances are used as one way to cope with mental health challenges, and vice versa. Sometimes people who are struggling with substance challenges that can contribute to feelings of anxiety or depression because of the range of ripple effects from that. And we have data that shows that. So, every year SAMHSA does a survey we call the NISDA. It's the National Survey on Drug Use and Health, a fairly significant national survey. And so the NISDA 2020 data, which means it's a 2020 survey, it means it's on 2019 data. It shows that there are about 61 million Americans that are reporting both mental health and substance use challenges. And of that 61 million, 3.8%, or 9.5 million, are experiencing some form of co-occurring disorder, so mental health and substance use challenges. Now, when we look at that a little bit more specifically, that means, for example, 1 in 6 individuals that report marijuana use also reported major depression. Or, for example, 1 in 5 individuals that reported opioid use also reported major depression. We say the same thing with methamphetamines. With methamphetamines or stimulants, 1 in 4 individuals that reported methamphetamine use also reported major depression. So we do see this co-occurrence often with mental health and substance use challenges. And I think the thing that's important there is that, there are services and supports that are available that can help people that are struggling with co-occurring disorders. And so I think the main thing, we talked about hope earlier. And I'm a full believer in the importance of hope. I think peer support specialists can help to bring that, but also people knowing that there are services and supports and help that is available. So if a person is struggling with either one of those, there is help that's available that can help them to live a full, whole, meaningful life and get to a better place in their life.
If I can jump in, I would just want to add that, we really have to be upfront and real with how common, mental health struggles are. Depression is the #1 cause of disability worldwide. It's not, heart issues. It's not, accidents. It's depression. Anxiety is the most common, mental health illness. And these are things that, almost everybody experiences at some point in their lives. And everybody usually tries to find a way to cope with those things. For one person, it may be Netflix. For another person, it may be family, if they have that support system. For a lot of people who don't necessarily have that support system, they may turn to substances. It could be alcohol, it could be something illegal. And so I think it's just important to also, when we are talking about the co-occurrence of mental health issues and substance used to be real, tell like it is, if you don't have assistance with processing things, with really addressing the things that you're dealing with, one, it's natural to try to find a way to cope with those things. But two, every coping mechanism isn't necessarily a healthy one. And so if there's an unhealthy coping mechanism that you start to use to deal with a mental health issue, we need to see how we can help with that so that, you can have that hope and, you can live, a meaningful life.
Yeah, that's right. And Dr. Jackson, was there anything that you wanted to add kind of from what you've been seeing on the ground?
I think that hope is like, it's like a pilot light of the soul. There's something that happens to the human soul when hope is extinguished. And what I know for sure is that when hope is gone, life is nearly over. I think when folks are turning to substances for coping, like my colleagues have spoken about, the true condition is that loss of hope, that loss of connection, that searching for relief. And I don't think we're going to get very far in our policies around substance use until we actually address and name the loss of hope that so many people are feeling for their lives and for their health. That is the true epidemic.
Yeah, thank you for that. And I wanted to stick with you for a second and ask you, I know that you work with LGBTQ individuals and transgender and gender nonconforming folk. And so for a myriad of reasons, things have not been going well during the pandemic. And so I wanted to hear from you, what challenges have you faced in connecting with Black LGBTQ and TGNC folk who come to seek behavioral health and social services? And what successes have you encountered?
Thank you so much for that question and the opportunity to speak about my work at Howard Brown Health. And for folks who don't know, we're, like I mentioned, a federally qualified health center. We see folks regardless of the ability to pay. Our core mission is to serve the LGBTQ community, the gender nonconforming community. When you take those identities and then you mix it with being a racial minority, like I often say, and I think of my one Instagram post I wrote, "We are not free until Black trans women are free," and I really believe that. All of the hard parts about being Black are there on top of living in a society where, unfortunately, folks are not free to express their true nature, whatever that means for them. And I think that kind of oppression really, really, really hurts the mind in ways we are only beginning to understand. We talked about cultural competence, and often when we say that, it's code for racial cultural competence. But I think what often gets missed is how other identities that can come with race also come into play in the medical and healthcare relationship. In our work, we call it affirming care. What we mean by that is we want to help people get to a provider of healthcare that looks at them and affirms, "I see you, you are okay, you are beautiful in my eyes," which is not a word we use in medicine. We're way too sterile for that most of the time. But the trauma cannot be overstated. It cannot be overstated. And so for our work, we focus on creating space where people can express their true nature. And although we're still in a place politically and socially where we specify that as LGBTQ, gender nonconforming, we have a lot of ways of cutting it. But I think at the core, our mission is freedom for all folks, regardless of what they call themselves, how they express themselves. Everyone deserves the right to health. So I think the solution, the action item, if you would be that we expand our view of what it means to be culturally competent and make sure that we're including folks who are on the gender and sexual minority spectrum when we talk about cultural competence. in terms of success, I think we do really well. And it's amazing. Certainly not saying we're perfect, but I think what sets us apart is just that will to recognize folks for where they are.
Yeah, thank you for sharing that, and really glad to have your perspective on this panel, since you will work with these individuals. And so we're beginning to kind of ramp down a little bit. So I want to turn a little bit more to solution or to policies that can aid the solution to helping to increase mental health access in Black communities. So Dr. Jackson and then Dr. Delphin-Rittman, I want to ask if there was one policy solution to improve mental health care and access in Black communities that you wish could be enacted tomorrow, what would that be? And then kind of a second question is, what is one small action that everyone who is watching this panel can put into practice today to improve their mental health wellness in their lives and in the lives of folks in their community?
Okay, don't get mad at me, but I'm that kid that I just can't. It hurts my spirit to try to dig one policy, but instead I'll say this. My hope is that we will take this question and understand that it is about a commitment to ongoing change. There is no one policy. I would probably throw you something about mental health parity, universal health care. I could throw some things out, but no matter what I told you, I would fear and feel that I wasn't representing the full scope of this issue. It takes all hands on deck, every single politician, every one of us to step up. When it comes to what is one small action that everyone watching this can do to put into practice to improve the mental health of the Black community, I think if I could speak to Black folks, it would be one, we understand that society, the world, your doctor, may not be validating your experiences right now. So I think the one thing you can do for yourself, something I do for myself, I try every morning, is to say, my pain is real. My pain matters. And it doesn't matter, what doesn't matter is if somebody else can name it for me. What matters is I tell the truth to myself and I validate my own experience. So I think starting with that as a first step, as a little light in your own heart, tell yourself, I see myself, I believe myself, and I am worthy of help.
That's fantastic. So I'll start with that one, and then I'll do the policy question first, because it relates to that. And I so appreciate your perspective in terms of, every day starting with those affirmations. And in some ways, it sort of relates to the piece I was thinking about in terms of self-care. I think that's one thing that we can do individually, and we can help to promote for others that could help the Black community, but even more broadly, but certainly, the Black community, that it's okay for us to not be okay, but it's okay and so important to take care of ourselves each and every day, whatever that means for us. Maybe it means like going for a walk or trying to eat a little bit more healthy, or not engaging or not, not as much screen time. I've been trying to reduce my social media in the evening because I notice if I'm on it real late, then I sometimes don't fall asleep right away because I'm still, and there's studies that actually show the blue light impacts. So self-care, I think, is a real important area that I think can help to improve the overall health and well-being of the Black community. In terms of a policy area, it's actually something that's in process right now at SAMHSA. I wish it would be done tomorrow, but it's a major system change. So, to do a major system change it's important to give it the time that it needs. And so what we're working on is a major overhaul of the crisis response system. It will include call centers, so a new national number, 988, and then enhanced and expanded crisis response teams, so that when a person calls 988, trained counselor can come. Will reduce the need for police officers, but then also standing up crisis stabilization centers or places to take people when they're in crisis, so they don't have to go to the emergency room. And so that is a major system transformation that I'm real excited about. And I think it will be a game changer in terms of how we manage crisis and suicide prevention. So stay tuned. That's on the horizon.
No, that's great. I'm very excited about that. So Dr. Anthony, I wanted to ask you if there was what advice would you have for someone who wants to show up for a Black person in their life who might be struggling with pandemic-related mental health issues and may not know where to start with seeking professional treatment?
I would say, start out by being kind. We exist in a world that isn't kind to us, so it falls on us to be kind to each other. So with that, listen, give the person space to talk to you without fear of judgment or fear of retaliation. Just listen. And I think, as you start listening to your loved ones, to your family members, you'll be surprised what you actually learn from them. Everybody is going through something. And then after you listen, encourage them to continue sharing, but also encourage them to start interacting with healthcare, with mental health providers that work for them, that are truly concerned about their well-being and that are providing the care that they need for their mental health. One of my advices is, you shouldn't be scared to shop around for a therapist because every therapist isn't going to get it. I have my therapist that I'm hopefully stuck to for life, but sometimes it takes time to find somebody that can really understand where you're coming from. And so if the first one doesn't work for you, don't be scared to get back out there and try again. But in terms of, individuals, start out by listening, something that we can all do. We can all encourage. We've all been through a lot in general, but especially, this past year. And for a lot of us, access to, these different resources have been decreased quite substantially. And so we've really had to rely on each other, and just having that space to converse, having that space to connect, because a lot of us have become increasingly disconnected over the last year. I think that really helps our friends and our families to, maybe take that first step in, engaging with mental health care or the other resources that they may need.
Yeah, thank you. And so we're running on time a little bit. So so I wanted to give each of you 30 seconds to say anything that we didn't get to address or that you wanted to make sure that the people who are watching this know before we close out. So I'll start with Dr. Anthony, since you were talking. Anything else in 30 seconds that you want us to all take home?
Yes. For anybody who's watching, just, remember that mental health care is healthcare. It's no different from your physical health. Make sure that you're managing it. Make sure that you're taking time for yourself. Be kind to yourself. Take care of yourself. Take care of your family. Don't be scared to step back. A lot of times we are told that we have to keep performing and pushing, but I'm very thankful for recent examples that we have seen, Naomi Osaka and Simone Biles. It's okay to step back if you need to give you the strength to jump back in the game later on. So just know that there are resources out there for you and that we are rooting for you and that we love you.
I would just like to build on some of those themes. I love that. I mean, I think it's important for people to have hope, know that there is help and support available if you're struggling. If you're feeling isolated or lonely, reach out, connect. A phone call sometimes can go a long way, or a text or a chat. So know that there is help and support available. Recovery is real and possible. And if there's anyone struggling, there is a national helpline that SAMHSA runs, and it can help connect you to services anywhere in the country. That number is 1-800-622-HELP, 1-800-662. So 1-800-662-HELP, and that's a national helpline that can connect folks to services and supports anywhere across the country. Thank you.
And Dr. Jackson.
Thank you so much again for having me. To Black folks, I want to say that you are not alone. Although hope is a delicate thing, it's very hard to kill, and we're a very strong people. To those who are in government, in my field of medicine and social services, anyone who's holding positions of power, I say this: the greatest act of revolution, in my eyes, is to tell the truth. First, to tell the truth to yourself, then to tell the truth to the people that you love, and then tell the truth to the world. Thank you for having me.
Oh, I love that. That's a beautiful way to end this panel. So thank you all so much for being on this panel. We've talked about such amazing, such great topics, and I think people can both policymakers, government, everyone can kind of go, and doctors can go home and think about how to implement some of the things we've talked about in their lives and in their profession. I want to thank the speakers, Dr. Anthony, Dr. Delphin Rittman, Dr. Jackson. You've all brought your truth today, and we've had a really beautiful discussion. So I'm so happy and so grateful to have been part of this discussion. I want to thank the staff, Congresswoman Kelly's staff, shout out to Rachel and Ayanapwe for helping so much put this together. And thank you to the audience for watching. And so again, I'm Dr. Burgos, Senior Health Policy Advisor for Congresswoman Kelly. And so now I will turn it over to Congresswoman Kelly to close us out.
Thank you guys so much. You were all so inspirational, and also you gave so much hope. Dr. Miriam, when you talked about taking care of yourself, one of my favorite poems is "Life is a Theater, be careful who's in your front row." To Dr. Anthony, when you talked about Netflix, well, Hallmark does it for me. And Dr. Jackson, you guys do such great work at Howard Brown. Proud that you are in Chicago. I've been to your office, and next time I'm going to make sure you're there. And to Anita, you've done a great job. So thank you all so much. Thank you to the sponsors. And hopefully you've encouraged people today who've been watching that if they need help to reach out to someone, that would be the best outcome. Thank you so much.